if you're an ICU nurse, it's going to be very helpful because we're going to go into a deep dive into ventilators. But I think anybody listening, is great to understand like FiO2, the different forms of oxygen, how your patient's receiving it, and what's happening on a physiological level that we're going to dive into.
Yeah, so mechanical ventilation, that's an invasive sort of ventilation. Of course, you have some other things that are non-invasive that also help with ventilation and oxygenation, like your CPAP, like your BiPAPs, your face mask, non-breathers, all those things. But today we're going to talk more about the actual ventilator. So it's like the more invasive. That's like your full life support, you could say. So why would we use mechanical ventilation? Majority of the time, you're going to see somebody on mechanical ventilator. That's usually post-op. If we're prepping somebody for surgery, and if it's like an extensive surgery, we're going to have to mechanically vent them. Some other issues that might arise that require mechanical ventilation is going to be respiratory failure, respiratory arrest, failure to oxygenate. So if measures like, let's just say your patient walks in and they require 5 liters nasal cannula, 6 liters, and then throughout the night they start to progress in the wrong direction. So we go from 5 liters to like a face mask to a non-rebreather, and now they need a CPAP or a BiPAP, and their oxygenation is still not appropriate. They're still setting like 85, 86. You guys decide to draw an ABG and the ABG numbers are off. Your next step is going to be to invasively ventilate somebody, so put them on the ventilator.
Call that RT, get us over there.
Yeah, because you can't, if someone's not being sustained on a BiPAP, you can't just pray and hope for the best and hopefully it changes. It doesn't work like that. You gotta unfortunately intubate them and figure out what's the underlying issue and then go from there. Another
I was going to say, it's also good is if you have a patient on BiPAP and they're like that for 3-4 days and they look like shit, they're breathing hard with their stomach, you see their ribs expanding, they're getting worked up, that patient has a high likelihood of not getting better. They're only going to decompensate. So sometimes there's a benefit to intubate them for 3-4 days, get their ventilation, get their airway back where it's supposed to, and as far as CO2, pH, and all that saturation, and then getting them off the ventilator.
Yeah, it's almost like you're intubating them to prevent them from like coding, because people could go for a long time with dyspneic and struggling to breathe. They go for a long time because the body is almost limitless when it comes to survival, but we don't want them to tire out and then just go respiratory rest. So a lot of times we intubate them before they emergency to get intubated. Another reason why you want to intubate somebody is air protection. Somebody could come in having an allergic reaction that's closing out their throat muscles and they can't breathe. And you don't want, because once the muscles and like your throat swell up, you're not gonna be able to get air in. So we intubate them in that way. Or for example, if someone's aspirating, we can intubate that to prevent aspiration pneumonia. And then also concerning findings. So if someone's looks like they're struggling to breathe, the best test you could do is an ABG. So your ABG is going to show you the pH, your oxygen status, the CO2, and your bicarb. So you're actually going to see how efficient your patient is actually oxygenating and ventilating the blood, you could say. Telling the oxygen and ventilating the body, but then the blood is going to have a direct response to how well they are. And if the numbers are poor, for example, the pH is less than 7.25, or the CO2 is high, it's greater than 50, respiratory rate is above 30s, and their O2 sats in the low 80s, those are probably some indicators that, hey, we probably have to intubate this person because they're not going to be able to stay in this way for much longer. And you want to avoid a code. Of course, you want to avoid a code.
And also keep in mind that these numbers are not always definite. It's a case-per-case basis. For example, if you have someone with COPD, naturally they're going to have a higher CO2. It could be up to the range of 50s, which is chronically hypercapnic. For some patients that have CO2s above 50s on their blood gas, they're probably like somnolent, very out of it. They could barely wake up. For a COPD patient, that's their baseline. And if you're a smoker, so case by case, it's not definite. But yeah, above 50, we're trying to find out what's the underlying cause of this high CO2.